Assalamu alaikum, everybody, and welcome to the webinar. It's Ramadan approaching, and we pray from BIMA that you have a successful Ramadan. In Surah Baqarah, verse 2, ayah 183, it says, "O you who have believed, decreed upon you is fasting, as it was decreed upon those before you, that you may become righteous." Ramadan is a gift from Allah, an opportunity for us as Muslims to capitalize on and earn his blessings, and a way to seek salvation and forgiveness. Over and over again, Allah Ta'ala helps us. He loves us so much. He wants us to reach paradise. He gives us opportunities time and time again to reach paradise. We have the fasting, we have zakat, we have all the good deeds that we could benefit from even more in Ramadan. We have the extra prayers as well. On a personal note, many Muslims that I know, including some family members, have passed away in Ramadan, and they are not going to see another Ramadan. And also, we don't know that next year we'll see a Ramadan through. So I'd like to encourage everybody that we should make the most of Ramadan, especially this year, and every opportunity that we get. Let's make this Ramadan the best Ramadan yet. Stay blessed. May Allah accept all your fasts and good deeds. Ameen.
Okay, for that reminder. So we'll be sending feedback forms at the end of the webinar as well. So if you at the end, and so if you fill in those feedback forms, you can leave your email addresses and we can send out certificates of attendance. So without wasting any more time, I'd like to invite Dr. Naveed Younis, who is an endocrinologist. He graduated from the University of Manchester in 1993 and trained in the Northwest. He's been a Clinical Research Ophthalmology Fellow in Liverpool, studying aspects of retinopathy screening, and has published very widely in this field. His more recent works have looked at cardiovascular disease and diabetes. Dr. Younis has been a consultant physician at Manchester University Foundation Trust since 2004 and is currently the clinical lead. On diabetic foot and renal diabetes in South Manchester and has vast clinical experience in managing complex patients with diabetes. He leads on complex diabetic foot service and is an accredited educator for DAFNE type 1 diabetes mellitus and delivers on the Warwick program locally. He's a past member of the Greater Manchester Medicines Management Group and has been involved in the development of key primary care diabetes guidelines in the region. He was the highest specialist training program director in endocrinology from 2007 to 2017 and is currently regional specialty advisor. He has developed local and national postgraduate educational courses in diabetes and is an online tutor for the Cardiff Postgraduate Diabetes Diploma and MSc course. So we're quite blessed to have him speak with us today. So Dr. Younis, if you could please begin. I'll just share your screen so we get your slides. Perfect. We've got your screens on we've got your slides on the screen now.
Okay, Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I hope you can all hear me clearly. My name is Naveed Younis, and thank you very much for the kind introduction. I'm going to give you some a talk on general aspects of managing individuals with health problems during Ramadan, and I'm sure you're aware that it's sometimes all the advice that I give you is very general. The advice I tend to sort of say to healthcare practitioners is often an individual will have some thoughts about fasting, thoughts about the health risks of fasting, and as healthcare practitioners we should try to encourage those individuals who are healthy enough to continue to fast, and those individuals who may develop problems during fasting, maybe the health may become worse, that this is that fasting should be restrained, or they shouldn't really decide to fast. But I'll talk about a little bit more about this in more details. So the aims of my presentation is to understand Ramadan and understand some of the medical restrictions of fasting with medication during Ramadan. And sometimes this can be quite confusing for healthcare practitioners. There are clearly lots of work being done on this area, and a foundation called the Diabetes and Ramadan Foundation have done a lot of work in this area, and Muslim scholars, religious groups of Muslim scholars have now all really agreed on the principles of which medications are allowed during fasting, which are the restrictions of fasting medication, which I will talk about. Then we'll talk about perhaps some medical aspects that I deal with on a day-to-day basis of looking after patients in clinics and perhaps patients that you see in your practice. So why is it an important topic in our population? Well, as we know, diabetes is very common in our area, in our population. If you look at around the world, 23% of the world's population are Muslims, roughly 2010. And if you look at number of individuals living with diabetes, it amounts to roughly about 382 million people around the world wide. So very large numbers of people living with diabetes. And that's, roughly equates to around about 90 million Muslim population with diabetes. If you look at the UK, just on our scale, there are roughly around about, if you look at 4.5 million people in the United Kingdom diagnosed with diabetes, and around about 400,000 people will be British Muslims who have diabetes. So it is a significant health issue. In some areas that I work in Manchester, where I am based in the UK, we have areas of pockets of Manchester where there are something like 80% of the population who attend their GPs are Muslim patients, and around about 30% will have diabetes. So it is really a great issue. As you know, diabetes is 2 to 4 times more common in patients in the UK with Muslim patients compared to those who are non-Muslim. So it's clearly a significant issue. A lot of work has been done over the last 10 years to make it very clear and to understand some of the risks of fasting with diabetes. We all know that fasting is around the corner, and perhaps tomorrow we will start our fast, or maybe the day after we will start our fast. And it's clearly one of our 5. Just a reminder, it's one of our 5 pillars of Islam. And really, fasting is obligatory with all, with some there's very few exceptions really. And of course, we all encourage our patients. Our patients will have their religious beliefs about fasting, and the decision to fast will be their own decision. And of course, we should support that as healthcare practitioners. I always, encourage my patients who feel that they can fast to continue to fast. And I think when patients come to me, they may have their own viewpoint. I will have to give their medical aspect. They will also have their religious beliefs as well. So just a reminder of the audience, really, as you know, this year, it may, actually the date is wrong. Today is the 5th of May. It may commence on the 6th or even the 7th of May, depending on the sighting of the moon. And as you know, the duration of the fast in the UK at the moment can vary quite significantly, but roughly will be roughly about 17 to 18 hours of fasting, depending on which part of the UK you are going to be based on. This will get slightly easier as over the next decade, as the calendar compared to the Georgian calendar moves closer towards the winter months. And of course, this poses significant problems for our patients, particularly if it becomes a very hot weather. At the moment, I'm sitting in my office in Manchester, and the weather is quite cold outside. It's about 9–10 degrees. But as you know, this can change quite significantly. This can become quite warm, and that poses significant problems for our patients, particularly with the long duration of fast and the potential risks of dehydration, which I will try and cover. As you know, there's very lot of work done and research done looking at the effects of diet on patients with diabetes. In general, and this is only a very smart generalization, because we know that although I have clumped all the Muslim population together, it actually varies. Muslims are very different cultures, come from very different countries, and have very different diets as well. But in general, two main meals are held during the day. As a reminder, you know, the suhoor meal, the sahari meal, and the iftari meal. And they're generally two main meals of the day, and very little is eaten outside those meals. It does vary in the time of the year. If it comes very, very early, or if it becomes in the winter months, often 3 meals ahead during the day. Diets changes, we know very well from studies. There's increase in intake of carbohydrates, sugary drinks, fried foods, carbohydrate, refined carbohydrate, and sweets, which really poses significant problems for our patients with diabetes. And sometimes advising patients is always important, to advise that to try and stick to a healthy diet as part of their healthy well-being in patients. I'm just going to just share a study called the CREED study. This was a fairly recent study, and it looked at patients and in terms of what actual proportion size. And although there is a large number of things over here, it shares that most people will have on average 2 meals a day. So 64% of the population will have 2 meals a day. Some actually will have 3 meals a day. And in general, the proportion size of the meals will get bigger, and the calorific intake will get bigger. More carbohydrate, more protein, and more fat, which actually means that more patients are likely to gain weight during this intake of Ramadan, unless, of course, they exercise more to lose that weight as well. If you look at, this is a population study in Pakistan, an urban population in Pakistan, but a very similar study has been done in the UK population as well, in the UK Muslim population, and around about 35% of patients unfortunately do gain weight during Ramadan. So a small number of patients lose weight, but about 37% of patients gain weight. The majority actually don't lose any weight, or don't lose any weight at all. So I remind my patients that you know, the patients are exempt, who are exempt from fasting during Ramadan. And clearly, this can be quite a difficult subject to look at, really, because if you have hypertension, often you don't have any symptoms. If you have diabetes that is diet controlled, that's relatively well managed, that doesn't really need any medication, generally that risk of fasting is very minimal, and it's unlikely to cause any problems during the time of fasting. But clearly, some patients with diabetes have a lot of complications. So an example would be somebody on dialysis treatment because of end-stage renal failure, and somebody with hypoglycemia unawareness, that they cannot record their blood sugars if they drop to very low values, and they're potentially at risk of having serious hypoglycemia. So of course, I remind patients that you're exempt from fasting in this situation, and to cause yourself more harm, then it would be, God's will would not be allowed to allow you to fast, and you're exempt from fasting. And of course, I remind patients to donate money to a person who cannot afford to eat, or if there are health issues at that particular point in time. For example, they may need antibiotic treatment, they may have a foot ulcer, they might need antibiotic treatment. Fast at a later date if possible. So I do remind my patients about these specific factors. And the decision to fast really is based on a number of factors: that individual's beliefs, the religious beliefs and the religious practitioners and the religious views of that individual, and of course where I think I fit in is the medical opinion. So often we are asked to give an opinion on whether it is safe or not safe to fast, and often I will go back and look at my thoughts about that individual and how risky it is. Sometimes it's quite straightforward, sometimes it's not so straightforward, sometimes there isn't an agreement, even when you talk to other scholars who are expertise in that subject, whether it is safe or not safe to fast. And sometimes people will then come around and make a decision on whether to fast or not to fast. So just a reminder about exemption of fasting. I'm sure this audience will all know about this, but children, pregnant women, travelers, menstruation in females, and patients who have got significant mental capacity that they would not able to comply with fasting, and of course those who are ill, which is a generalization, of course, full stop. Now, if you look at these individuals, and if you look at a large number of these individuals, in fact, will actually fast. So, you know, we know in the Muslim population, a large number of children do fast, young children do fast, but they're in general exempt from fasting. If we look at patients with diabetes, and if we look at how often and what percentage fast, so type 1 diabetes, this is an old study looking at the EPIDAR study, looking at 13,000 patients, and did a prevalence study looking at how often these patients will fast. And around about 43% of patients with type 1 diabetes fast, and about 80% of patients with type 2 diabetes do fast. This population was a population in the Middle Eastern countries in the majority, but it does show you that even in those high-risk groups of individuals, you know, a significant proportion of patients believe that they would want to fast, you know, regardless of whether our advice. So it's important to remember that. Now, I think I just want to highlight a few important points, because these are the important points that always come up whenever I'm doing a presentation. So blood glucose testing. Often patients come to me and say, well, I don't want to test my blood sugars because that invalidates the fast. That's incorrect. Muslim scholars believe that this is valid, and you can do blood glucose testing throughout. And in fact, I do encourage my patients who are blood glucose testing to test more frequently, because the effects of fasting might become more apparent. So, for example, somebody starts to fast, their blood sugar levels drop too low, they should stop the fast. And it's important that if you do have a hypoglycemic event, so if your blood sugar drops below 4 millimoles, that you should stop the fast. You shouldn't really cause yourself any harm, and potentially those patients may be at risk of developing severe hypos. And again, patients with very high blood sugar levels, again, stopping the fast is important. High blood sugar levels potentially can be dangerous as well, can lead to various symptoms of thirst, dehydration. So it's important to, you know, remind patients about the decision to stop fasting. And in general, some patients come to me and say, well, you know, I don't want to take my insulin during the period of fasting, and I'd rather take it before my period. And I actually say, well, insulin has no nutritional value, and certain types of insulin, for example, longer acting types of insulin, are quite safe to be given in fasting and don't have any problem at all. So, you know, you can still inject. It's no nutritional value. And we have other drugs that we use very commonly in diabetes called GLP-1 analogs. These are injectable treatments. They're given either weekly or sometimes daily or twice daily. And these are injectable treatments that don't contain any nutritional value. So again, I say to my patients, look, you can take these medications. You don't have to take it with food. It's absolutely safe to take it. But, you know, you can always change the timing if you want to. You can change the timing of this treatment, particularly with GLP-1, to the time of non-fasting during the day. And again, you know, it's important to advise when it is safe to continue to fast and when it isn't safe not to continue to fast. So I'm going to highlight some of these points in more detail. So how does fasting affect patients with diabetes? And in general, we know that as somebody starts to fast, and this is in a normal, healthy individual, you know, we start to use glucose and release glucose, glycogen. Remember, in the medical school days, glycogen is broken down to glucose. Glucose is released into the circulation, and that maintains our diet. The glucose is broken down, and also protein and fats are broken down to form ketones or ketogenesis, and that maintains glucose to be used as a source of fuel. So in somebody without diabetes, you know, we maintain very, very, very tight blood glucose levels without any significant problems. In patients with diabetes, we know that they have too much breakdown of glycogen, and that can cause increased levels of glucose. Eventually, those glucose stores are all used up, and potentially that can lead to very high levels of glucose. And because there's a lack of insulin, that potentially, if insulin doses are not adjusted, can lead to ketoacidosis. Now, this slide shows you what happens in somebody with diabetes and without diabetes. Sorry, without diabetes, which is in the top graph, which really shows you that the glucose levels remain very, very tightly controlled between 5 and 6. At the iftar, heavy meal, at the iftar meal, very high, a slightly peak in glucose levels, but maintain very, very controlled levels compared to fasting and non-fasting. So in non-fasting, it's blue, absolutely straight, and in fasting, absolutely straight. And in somebody with diabetes, you get more swings of blood glucose. You get the lowest blood glucose values at the point just before iftar, because that's the point where all the glucose stores are being used up, and potentially the medication may cause you to drop your blood glucose values, and therefore the risk of having hypoglycemia. Of course, when you have a very big meal, you get a very big rise in glucose, which is normal in people who have diabetes, and then it eventually comes down. So the risk of hypoglycemia is particularly great around about the time just before iftar, just before they open their fast. So these are the sort of risks that are associated with fasting. Just a reminder, really. Hypoglycemia, depending on the medication. Hyperglycemia, again, depending on whether the patient stops the medication, adjusts the medication, stops taking the medication. Dehydration, particularly in the hot climates, and that can indeed lead to increased risk of thrombosis, dehydration, and hyperglycemia in itself. The longer the fast, the higher the risk this may occur. And of course, you know, we don't lose weight in fasting because we replenish our stores of carbohydrate because we eat food at night time. So hypoglycemia is mainly in those patients on sulfonylurea and insulin therapy. Hyperglycemia, that's usually due to patients stopping their insulin and or reducing their insulin doses and not seeking advice about this. Often it might be due to increased intake of food and sugar as well, particularly those patients with type 1 diabetes. And patients with type 1 diabetes stopping their insulin or reducing their insulin too excessively. And again, dehydration I've mentioned, and hypoglycemia. Those are more of a problem really in climates where there are very high temperatures. So example, if you're fasting at the moment in the Middle East, the temperature there is about 34, 35 degrees. So you can imagine fasting for a significant period of time can pose you the risks of dehydration. Body weight changes, and interestingly, generally most patients don't have any changes. A small number of patients do gain weight, a small number do weight loss, both in type 1 and type 2 diabetes. And this is the change in medication. So insulin is a treatment which is dependent on, if you look at patients on insulin on type 1 diabetes, you'd expect very significant changes in doses of medication. But in fact, studies have shown that actually very few people actually alter their dosage of medication and maintain the same amount of insulin. So it's significant because that can cause significant problems. And it's similar for patients with type 2 diabetes on insulin, where perhaps very few people make changes to their medication. A lot of work has been done in Ramadan looking at the type of advice, and of course these are started in 1995. We had a lot of consensus documents, and the most important document that we have at the moment, the most comprehensive subject review, is done by the International Diabetes Federation and the Diabetes and Ramadan International Alliance, where we produced some practical guidelines on fasting in Ramadan, produced in 2016. This is downloadable and contains a lot of details about fasting. And really, I'm going to summarize some of their advice in the next few slides. A very useful document for patients, I think, is this document, which is produced by the Muslim Council of Britain and Diabetes UK. It's a patient information leaflet. It tells you about what to do in Ramadan, what medication advice they generally give, and what you should do if you stop, why you should stop fasting, what is a hypoglycemia, because often patients never had a hypoglycemia, and what is very unsafe levels of blood glucose. So I always give it to my patients who are fasting and need some educational advice on this. It's a very, very useful document. I would strongly recommend this. So the IDF produced a number of guidance and recommendations of which categories of risks. These are what we call the very high risk group of patients, and I'll just list a few of those. So patients with severe hypoglycemia, so patients who come into hospital who have severe hypos, need paramedic support, patients with unstable diabetes, diabetic ketoacidosis, or hyperosmolar hypoglycemia, HHS as we call it, and patients with poorly controlled type 1 diabetes, and of course patients with significant kidney disease. You know, their risk of dehydration is significant, so their risk of altering fluid and medication may cause them kidneys to get worse. So we advise them not to fast. And of course, these are the sort of high risk groups. What we also call high risk group, not as high as the very high risk group, but also significant risk. And again, so even well-controlled patients with type 1 diabetes, type 2 diabetes and insulin, pregnant women or gestational diabetes controlled by diet or metformin, patients with CKD stage 3, and patients with other comorbid conditions that might complications that might be made worse during fasting. So that's a general group. And this is what I call the sort of moderate to low risk group. These are patients who are controlled on the following therapies. So lifestyle treatment alone, so just diet alone. Patients controlled in any one of the following or combination of the following treatments are all deemed to be safe to fast. Now note that in there it contains sulfonylurea, second generation sulfonylureas, and then in the UK certainly you would use second generation sulfonylureas. Well, this is medication like gliclazide, glimepiride, and of course these are generally used in the UK. Other therapies there are insulin, so basal incretin, so this is something like insulin glargine, a Basaglar, Lantus, or other insulins. These are all the sort of types of insulins that we use, and these are very flat, straightforward insulins that then generally don't cause hypoglycemia unless you're on to a higher dose. So these are considered to be safe. In general, those patients in the first two categories that I've listed should be refrained from fasting or advised not to fast. And of course, although we advise not to fast, or we would advise as a medical advice not to fast, many of these individuals will choose to fast. In the third group of individuals, those are deemed to be safe to fast. So in the last group that I mentioned, this group, these patients are deemed to be safe to fast with this medication. So ideally, in the very high risk group, if the patients insist on fasting, ideally they should have some structured education, followed up by a qualified diabetes team, giving advice on what to do with their medication, and ideally prior to Ramadan, and of course be prepared to stop the fast in case of hypo or hypoglycemia or worsening related problems. It's important that they should be given advice on this. So if you look at one study, the CREED study again, which I mentioned before, and if I looked at the number of patients who fast in this individual group, if you actually look at, this is data collected in 2010, but only got published in 2017. If you look at them, even in these categories were very high and high risk groups, they actually fasted for 23 or 27 and a half days. So in the very high risk, they fasted for 23, so almost the full complement of Ramadan, and 27 and a half days for the very high risk, the high risk groups. So despite all these guidelines, despite all the work that we do, patients tend to want to fast anyway. So it's important to remember that, it's important that we do remind our patients that they should, it's important that we should try and advise what to do with their medication and support them what they do with their medication if they do decide to fast. It also reminds you that the significant reported, these are self-reported hypoglycemia, about 7%, and 16% on insulin treatment did have significant hypoglycemia during this time. So it does remind you about the problem we have with patients during fasting. So these are the sort of general advice we do. Individualized advice is important. Blood glucose monitoring does not invalidate the fast. Nutritional advice for healthy diets and exercise, and generally my own view is we should stop the fast if the blood sugar drops to less than 4, which is hypoglycemia, and if it's persistently greater than 15, consider stopping the fast. That's not hard and wrong, that's not hard and right. Obviously, if somebody with very poor control throughout, ideally should have their controlled blood glucose controlled if they do decide to fast in any case. So ideally what we should do is, as I say, we allow to fast and we allow not to fast, but of course a lot of patients will decide to fast. Now, some specific advice in patients with diet? Generally, there's no problem with fasting, particularly if they're reasonably well controlled. The only real problem they might have if they have a very poor diet, they may have very high levels of blood sugar, but this is because their diabetes control is relatively stable. That's only a temporary thing that doesn't usually cause any problems. Fluid restrictions and dehydration, so encourage patients to drink plenty of water and to avoid the risk of thrombosis, particularly in warm climates. Metformin, patients on metformin treatment, generally on once a daily, no dose modifications really required. Ideally, I take it iftar because that's the main meal of the day, generally, and take it with the main meal of the day, less GI side effects, gastrointestinal side effects. If they're on twice a day, generally take it iftar and sahur, and no dose modification usually required. If you are having a very little sahur meal, then you might want to reduce and take the most of the dosage in the evening meal. 3 times a day dosing, again, I tend to avoid 3 times a day dosing, but take the morning dose before sahur and then combine the afternoon dosage with the iftar meal. Patients with prolonged release metformin, ideally that's usually not a problem. Take an iftar meal, and because it's prolonged release, it doesn't cause as much gastrointestinal side effects. Now, these are the type of therapies: pioglitazone, DPP-4 inhibitors, and GLP-1s that don't cause hypoglycemia. Generally safe, used in combination with other treatments are generally safe. Only real risk is if you're on sulfonylurea or insulin. You might need to dose modify the dose of sulfonylurea or insulin. They can be taken at iftar or the sahur meal. Weekly GLP-1 or injectable treatments have the advantage of less injection frequency, but again, these can be taken during the actual timing of fasting in any case. I'm going to ignore a couple of these slides, but sulfonylurea, these are very common therapies that we use in diabetes, and they do cause hypoglycemia. So ideally, if you want to take it, if you're taking it once a day, take it with the main meal of the day, and ideally that should be the iftar meal. So if they're well controlled, adjust the timing. If they're on twice a day, depending on how much meals they have, if they don't have much carbohydrate in the morning, you might want to reduce the sahur dose of the medication. Other older classes of drugs, as I said before, we should avoid taking these. Now, the SGLT2 inhibitors, they've been around for a while now. They can cause dehydration, particularly so I do advise my patients to take extra fluids with this, and ideally to take it at iftar in general. So they do sometimes cause a bit of extra fluid, and sometimes they do feel thirsty on these kind of treatments. So ideally, I do take it advise take it at the iftar meal, where they have free access to water after they open their fast. One study is called the Kratos study, which basically advised, patients. I looked at patients taking this during Ramadan and found it generally it was quite safe and well tolerated. Insulin, it's always very important to have specific advice for insulin. If they're on a basal insulin, you might want to reduce their dose. So if they're on a number of doses of long-acting, intermediate-acting insulin, they may have to reduce their doses. It says 15 to 30% on this slide, but again, it depends on their level of control. If their control is very poor, you don't really want to be reducing somebody's dose by 30%. So if they're well controlled, you might want to reduce their dose. If they're on twice-a-day insulin, and generally the morning dose of insulin needs to be reduced by about up to 50%, particularly because of the risk of hypoglycemia. So again, very specific advice. If they're well controlled, the dose reduction would be about 50%. If they're not well controlled, perhaps not as much as 50%. Short-acting insulins are generally taken with meals. Usually have a normal dose at iftar, but in your sahur meal, you might need to reduce that dose by 25 to 50%, to reduce that risk of hypoglycemia. And of course, because they're not eating at lunchtime, they wouldn't take their short-acting insulin then. So that's usually more straightforward. On patients with on pre-mix insulin, this is where it's always a problem. If they're on once-a-day dosing, take it at iftar. Most patients are on twice-a-day dosing, so they're on it in the morning or in the evening. So you really want to reduce their morning dosage by up to 25 to 50% and keep on blood glucose monitoring. If they do run into problems, you might need to stop the fast and ask them to blood glucose monitoring more frequently. Sometimes you reduced it too much, so you can push the dose up a little bit more. If they're on 3 times a day dosing, obviously omit the dose that they normally take it in the afternoon and carry out adjustment of the doses throughout the Ramadan period. Type 1 diabetes, really this needs specialist advice only really. We do adjust the dose of background insulin on the pumps, and we do reduce the doses of basal insulin, the background level of insulin, sometimes by up to 30 to 40% if taken at the iftar meal. And the bolus doses are usually normal. Most patients with type 1 diabetes are carb counting and have a formula to work out how much insulin they have for each carbs. So they can carry on using that formula, but they may need to just reduce that formula in the suhoor, because often as they fast, the risk of hypoglycemia is increased. So that's a summary of what I've just said. Important to give specific advice and use some of the therapies with caution in Ramadan. But again, if patients do insist, and as the evidence appears that most patients do insist on fasting, just to give practical advice. I thought I'd finish off with doing a few case studies, perhaps some real life case studies where patients have come to me and given specific advice. So this is Aftab. He's 48 years of age. He's had diabetes for 5 years. His blood sugar control is not good. His body mass index is high at 29. He's on metformin and a gliptin. His GFR is 46, so it's not very good kidney function. So the advice on him, so let's have a look what advice we would give on him. So his glycemic controls H1Cs, but his medication is not going to cause hypoglycemia currently. He does fall into the high risk category, CKD stage 3. But if he does insist on fasting, then you would consider reducing his pre-dawn dose of metformin. He's on 1 gram twice a day. He could take his allogliptin as it is. No need for blood glucose monitoring. His risk of hypoglycemia is low. He's unlikely to cause any problems during Ramadan. And really, following Ramadan, you need to consider improving on his glycemic blood sugar control. Another patient is Mohammed. He's a taxi driver, diabetes for about 8 years, overweight. His H1C is 60, so again, not very well controlled. He's on metformin twice a day and is on gliclazide once a day. He's fasted during Ramadan previously. He's asking for help to improve his blood sugar control without affecting his job or his wish to fast. So what's your advice on him? So is it safe to drive? So he's driving on fasting. He's at risk of hypoglycemia. If he stops his medication, his risk of going high. I would perhaps consider, as a safer option would be to stop his sulfonylurea tablet and switch over to either a DPP-4 inhibitor or an SGLT2 inhibitor. These medications don't cause hypoglycemia. They don't cause any problems, and it'll probably improve on his blood sugar control in any case. So, the options are either to take the gliclazide with an iftar meal, monitor his blood sugars. They're unlikely to cause a problem because in a very low dose, or stop the gliclazide and switch to an alternative a medication as well. So finally, this is Yusuf. He's 58 years of age. He's another cab driver. I'm not sure why they've always got cab drivers here. Diabetes for 5 years. He plays exercise, football. His H1C is not very good controlled. He's on metformin and a DPP-4 inhibitor and insulin. He's got retinopathy. He doesn't really do much routine exercise. Generally, he works very long hours. He's looking forward to fasting and the extra prayers in Ramadan. He does actually eat a lot of extra food. He's looking forward to this, but he also does a lot of extra prayers. He does a tarawih prayers at the masjid, and he can't walk there. He shares desserts with his friends as well, so he has a lot of heavy meals as well. He only checks his blood sugars when he's dry, but doesn't bother at other times. So what advice would you give? So he does actually fall into the group. His actually category is actually low risk category, so he's actually safe to fast. I think important to advise on blood glucose monitoring throughout to avoid hypoglycemia. He may need a dose adjustment of his background insulin. It's very difficult to advise what's going to happen. He might need a reduction of his background insulin, but I'd be very careful about doing that because it seems that he is actually eating a lot of extra food, which is going to make his blood sugar control worse. So in this case, what I would do with him is advise on blood glucose monitoring and then advise on adjustment of insulin if his blood sugar runs too low in the morning. So I'm going to stop there, but many patients with diabetes do insist on fasting during Ramadan, and many healthcare practitioners do insist on fasting, and many patients will should be aware of the potential risks associated with fasting and may make a different decision about fasting. We should try and educate our patients on meal planning, glucose monitoring, and necessary changes to medication. I think if you're experienced in managing diabetes, I think the management of diabetes in Ramadan is not a big issue, and I don't really think it should prevent somebody from fasting if they do. It's just us having the knowledge and advice on what to do with patients. Jazakallah, thank you very much. I'm happy to offer any supportive advice if you would like to offer the advice. Jazakallah, thank you.
Jazakallah khair for that insightful talk. We'd like to open up the floor for a question and answer session now. If you have any questions, please raise your hand and you can ask a question directly, or you can type it into the question box by opening up the question mark. So we've got a couple of questions that have come through in the question boxes. If I just hand them over to yourself, Dr. Younis.
Yep.
So Saeed asked so the first question is, what is the best time to exercise during fasting?
Yeah, in fact, the best time to exercise, it actually would be, it depends on what medication you're on. So if somebody with if somebody with diabetes, if they're on medication that can cause hypoglycemia, then actually the best time to have fasting is at the time when you potentially can avoid hypoglycemia. So actually after at sunset, between sunset and sunrise, that would be the best time to exercise. If you're on medication, the risk of hypoglycemia, you can treat that hypoglycemia. That would be the best time to exercise. Of course, if you're not on medication that can cause hypoglycemia, then actually there isn't really any advice on when is the best time to advise. Most patients, most patients who decide to exercise often exercise just before the iftar, and usually do a better exercise, shower, and then they if they feel a bit dehydrated, they're about to open their fast anyway. So I don't think there's a lot of work has been done specifically in diabetes, but in that general, that would be the advice that most of us would perhaps give.
Thank you. Thank you. So we've got another question. Does Diabetes UK and Muslim Council of Britain guidelines include advice for children with diabetes as well? Sorry,
just repeat the question.
So does the Diabetes UK, and I think they're referring to the guidelines you put on the screen, the little poster.
Does it apply to children? No. Yeah. The guidelines have all been done in adults, really. Very little work has been done in children with diabetes. Most children with diabetes will have type 1 diabetes. And as you know, the advice on type 1 diabetes, if children do decide to fast, will be very similar to the adult guidelines, but very little work has been done in children. And as you know, obviously children are exempt from fasting. The problem you have with children with diabetes is usually the control is much worse than in adults. So if you look at average glycemic control in the UK, the stipulated guidelines, say we should do the same, similar level of control, monitoring, etc. But often the control is very, very poor. The risk of hypoglycemia is significant. Children can't often, can't often tell that they're having hypoglycemia. We do have newer treatments that can try and help avoid hypoglycemia. So we have better glucose monitoring machines. We have devices now that can measure glucose. The Freestyle Libra device, which is like a little patch you put on your elbow, and you have a machine that reads over it, so you scan over it. Our Prime Minister has one, just to sort of highlight, and it does give you an idea. If you're going to drop, it has arrows going up and down and straight. So if you're going to drop, it has an arrow going downwards, and that's useful for adults. But so for children, I think it's again very similar principles apply. But I think for most will have type 1 diabetes, and most really should seek advice from their diabetes teams on what adjustment of medication should be done.
Thank you.
Thank you.
We've got a specific question for just like a case. Somebody's asking, I have type 1 diabetes. What do you advise if I have a hyperglycemic episode during the day? Will a corrective dose of quick-acting insulin be okay without breaking the fast?
Yeah, so that's a good question. So as you know, if you've got type 1 diabetes and you have very high levels of insulin, high levels of glucose. So in general, what we normally would advise is to take a quick-acting insulin to correct that at the next available meal, or take something to eat with insulin, and then bring, potentially that will bring down the blood sugars. Now, to take insulin without a meal is always at risk of having a hypoglycemia. So that's the problem you have, and it depends on the level, how high the blood sugar levels are. But insulin is always not very predictable when it's not taken with food. Therefore, the advice usually is to stop the fast and take a quick-acting shot of insulin to bring down the blood glucose levels, but with food as well. So really, they would have to break the fast. No healthcare practitioner would advise giving insulin, particularly a quick-acting insulin, without food. And we advise that on our patients with type 1 diabetes. If their blood sugars are very high, the same principles apply with patients with type 1 diabetes, who are fasting. The risk your risk you take is the risk of hypoglycemia. And again, that would be significant as well. Often insulin is unpredictable. I know patients do it. I know patients, if you are going to do that, if you want to try and maintain your fast, then I think you should be wary about giving the same normal amount of insulin that you would do to bring that blood glucose levels down. So you would normally give you a less amount of insulin to bring that blood sugar glucose levels down if you decide to do that. Thank you.
Jazakallah. So somebody's asking where they can access the diabetes advice leaflet from.
So for diabetes advice, if it's patient advice, I would recommend the document that I showed in the presentation, Muslim Council of Britain, and that would and the Diabetes UK document that I showed you. That was a very good patient advice. The general advice that I have given you is from the Diabetes and Ramadan Foundation, and this is a group who have done a lot of work and summarized all the evidence in their document. So that is freely available. If you type in diabetes and Ramadan in Google, you'll find their document. It's downloadable, it's free, and that will have a summary tables of all the advice on what we do with medication, specific advice what we would do with tablet treatment and medication, as I've summarized really in my part of my presentation.
Thank you. Somebody else is asking if they'll be able to have access to the slides.
Yes, I mean, I'm more than what I will do at the end of the presentation. Sorry, we had some technical issues, so I will forward it to BIMA, and I'm more than happy to share them. It'll be as a PDF, so I'm more than happy for you to share them and link it to your appraisals or read them at your leisure. So I'm more than happy to do that. Yes.
Thank you. Another question: what foods should we advise diabetic patients to have at sahur and iftar? Is the advice similar to what we advise healthy patients?
Yeah, so the advice is exactly right. We always should advise on healthy eating. That's always important. It really is, you know. I always say to my patients, and even to patients who have not got diabetes, you know, in family members, you know, friends, that we should try and, you know, the whole point of us fasting is to, you know, not to overindulge, you know, not to eat excessive. I know it's very difficult, you know. I think we come in cultures where, you know, we're fasting all day. We feel it should be a reward to eat, and our natural, you know, mind will say we're very hungry, we need to eat. There's lots of healthy, nice foods there, unhealthy, nice foods. But really, you know, I always say to patients, look, you know, potentially this is a way of controlling your weight, improving on your blood glucose levels, improving on blood sugar levels. Often patients lose weight, and that's usually the best way of managing type 2 diabetes, avoiding the need for tablets and treatments. And I've seen a lot of patients who really go on to continue to fast, you know, after Ramadan. In terms of in the morning, the suhoor meal, you know, I always advise patients to, if they're on medication that can cause hypoglycemia, take something. If they're going to take carbohydrate, really take something that's very long-lasting carbohydrate. So, you know, medication. So something with very low glycemic index type, low GI index type meals. So something like porridge, you know, chapati is actually very good because that, you know, doesn't cause your blood sugar levels to rise very high, but actually causes it to rise very slowly and maintains your hunger a lot longer, you know, sort of thing. So you're not as hungry during the onset of the fast and during the day of the fast. It maintains your, it avoids hunger and cravings throughout the rest of the day. So actually those kind of meals, whereas things like breakfast cereals, if you look at breakfast cereals, you know, we often sometimes have a cereal at suhoor and things. Actually, it contains a lot of sugar in there, and that actually stimulates the brain to have a craving. So those are no good in general. So avoid, you know, high, you know, refined foods. The best way to look at this is if you look at tables and look at glycemic index, and if you look at things with very high levels of glycemic index, those are things to avoid. So some people will take a glass of orange juice thinking, oh, this is great, you know, but actually it contains a lot of sugar, makes you very thirsty. You wanted something with a low glycemic index. Whereas eating a whole orange, because of the fiber in the orange, that means the sugar content of the orange is released very slowly and doesn't cause blood sugar levels to go very high. So it's much better. And it's the same with the iftar as well. You know, iftar, you know, you should really be trying to avoid these type of foods. I know things like pakoras, samosas, these kind of things, which are high not only in carbohydrate but also high in fat as well. So those will, you know, if you eat excessive amount of these, they will tend to put weight on. And of course, you know, a lot of people don't exercise, don't do as much activity during Ramadan. So, you know, they tend to put weight on if they're not exercising, they're eating the wrong types of foods. Thank you, Jazakallah.
I think we've got one last question.
Yes.
I don't know if it was already answered. Somebody's asking about new medications such as dapagliflozin.
Yeah.
What should happen to that drug while somebody's fasting?
Yeah. Okay. Okay.
I don't know if you
So in patient, yeah. So I think I did cover it. The SGLT2 inhibitors are the tablets called dapagliflozin. They come under those categories, and generally, in those patients, you know, they can cause excessive thirst, excessive urination. So patients can urinate more frequently. And those are the main things. Ideally, you should start this before Ramadan, you know, sort of thing, so patients get used to the side effects, know about the tablet. And some patients have to be, you know, they have to drink a lot when they first start on these tablets. So it's not a good idea to start it in Ramadan. Generally, it is safe. It is safe. Some people will find that they have to go to the toilet, pass urine more frequently. You know, the general advice is perhaps take it at iftar. And if you're taking an iftar, you know, sort of thing, you're not as dehydrated. You thirst, you can quench your thirst with drinks and fluids. And generally, the side effects will, you know, the side effects will abate by the time. So they are generally safe. They don't cause hypoglycemia, and they help with maintaining weight loss in our diabetic patients. You know, they do cause weight loss in our patients with diabetes. So in general, that's the general advice. Only risk, I think, is in very, very hot climates. In the UK, you know, we might get very, very warm temperatures. So again, taking an iftar, taking a lot of extra fluids, you might want to be, advise your patients on if you're going to start you or if they're on this treatment.
Jazakallah khair. Somebody's again now just asked about what about euglycemic DKA and this medication? We're quite interested in this drug.
Yep. Okay. So this is a general question on diabetes rather than specific to Ramadan, but I'm happy to answer that. They do occur. So diabetic ketoacidosis does occur on this medication, and generally the reason it occurs is because usually patients have started on this medication and they're not eating as much. They're not eating particularly carbohydrates. So if they're on a carb-free diet, if they're well controlled with their glucose level, if they're thinner patients, so they're the slimmer type 2 diabetes patients, they're potentially at risk of euglycemic ketoacidosis. So, when you're on this kind of, a lot of patients go onto these kind of diets where they're onto low carb diets, the Atkins diet, low carb diets, 800 calorie diet. So you have to be very careful with this problem. Patients who develop urinary tract infections or patients who are unwell, generally for this kind of medication, you might want to stop this medication to avoid this happening. So if you've got a thin patient with diabetes, you really don't want to prescribe this medication. If you've got somebody who's very unwell, you would advise to do more glucose testing. If they're very unwell, they should really seek medical help in case they've got ketones and ketoacidosis. So in general, that's my advice. They are generally good medications. They're generally safe, but you remember you have to prescribe it in the right type of patient. Thank you.
Jazakallah khair. I think we'll wrap it up there. Thank you so much for all your time. This has been a very insightful talk. So Jazakallah khair for everybody who's attended today as well. This wraps up the main part of the webinar. We will be recording the webinar and putting it on YouTube. We'll also have feedback forms as well, and at the bottom of the feedback forms, if you put email addresses, we can send out certificates of attendance. So that's the end. What I'd like to do now is just give everybody a few words about what BIMA is and what the organization is. So if you want to stay for a few minutes now, we can go through that. But Jazakallah khair, Dr. Naveed, for all your time. So the British Islamic Medical Association is the organization that's brought you today's webinar. This is the professional development team, and we mainly run monthly webinars just about topics that are topical, that are affecting Muslims, that are affecting the wider community. But BIMA itself is a huge organization that was initially set up on June 22nd, 2013 in Leicester, and it was an amalgamation of lots of small different groups of Muslim doctors initially that wanted to come together and provide a support group for themselves and to help serve their community better. So a lot of small groups, and then they all came together and formed one united group. And since then, it's grown to hundreds of members and including lots of different health professionals, not just medics. And it's everybody that's got the same vision, which is to inspire each other, inspire our patients, inspire the community, is to inspire, to unite as one, and to serve each other, to serve the community. So anybody with that ethos, we'd love for them to join the organization and to help wherever they can. It's a completely volunteer-led organization. So there's lots of different branches of BIMA. There's the community service branch, trainees and students branch, advocacy, conferences and events, professional development, Ramadan initiative, the health promotion, and history medical ethics. All of these groups have been doing lots of work. We usually have like FY1 careers days and things like this for the trainees and students. There's events that we put on for the community, such as, so within health promotion and community service, there's the BIMA Lifesavers national program, which turns mosques into life-saving centers for one day of the year. And each year, more and more mosques have been participating, and we teach basic life support to anybody in the public, which is quite a big part of BIMA. We've also, so recently, because of Ramadan coming up, we've had lots of different Ramadan projects. So we've had like patient education programs, which have been running up and down the country at the moment. We've had 55 venues in which we give information to the public about how to stay healthy during Ramadan, promoting healthy lifestyles and dietary habits during this time of year. And BIMA members went into mosques, community centres, went onto radio stations, went onto TV stations to give this information out into the public. We've also, again, this webinar to educate healthcare professionals dealing with Muslims as well. So there's lots going on all the time. So there's quite a lot. There's the website where you can get more information. There's if there's any particular project that you're interested in, you can contact info@britishema.org and get your name down for something, get more information. It's also a support network, so different regions, the whole of the UK is split into regions, and there's regional WhatsApp groups. And so if you move due to training, you end up moving into a new area, you can network with other Muslim healthcare professionals, and they can provide support. So, and there's lots of seniors to junior members on the group, so there's a lot of support up and down as well. So there's lots of different initiatives and projects that you can get involved with. So if there's any more further questions, I want to keep this quite brief because we're already at the end of the 1 hour slot we had. So if there's any further questions, anything like that, please feel free to contact us. And we can close this session today. So thank you for listening. If you are happy to fill in the feedback forms at the end, we'll be able to send some, we can send out certificates. So I'll just close the webinar now. Subhana rabbika rabbil izzati amma yasifun wa salamun mursalin walhamdulillahi rabbil alamin. Assalamu alaikum wa rahmatullahi wa barakatuh.